Gracias, doctora, y bienvenida.
Good morning, everybody. Sorry, good afternoon. Let me just share my screen, and then we'll start in a second. Right. Can you all see my screen now?
Yes.
Yes.
Okay, awesome. Thank you. And hopefully the subtitles will show up in the bottom. I'm using Office 365 and I'll try to speak as slow as possible. But if I'm speaking loud, too fast, just interrupt me so that I can slow my pace. All right. So thank you so much first of all for having me here today. I love teaching and fenol neurolysis is definitely my passion. So today we're going to talk about neurolysis with phenol and alcohol. I do not have any conflicts of interest with this talk. And the main purpose of the main objectives today, we're going to discuss the indications for neurolysis in SCI and other population as well. Then we're going to review some data on the safety because often people are really concerned when it comes to phenol or ethanol that it's not safe and it can make people weaker. And we'll talk about that too. And then I have some videos, they're not very high quality, but I have some videos where I can show how we use ultrasound and electrical stimulation guidance to do phenol neurolysis. So I don't know if many of you know, phenol and ethanol neurolysis existed even before Botox or intrathecal baclofen pump came in. This is what people used to use for spasticity. And I used to have this book, but somehow I lost it. The only copy which I bought it from Amazon from Dr. Khalili. And he was in New York and he was the one who had written a small book and first used the phenol for spasticity. Sometimes actually they used to inject this inside the spinal cord to cause the complete loss of anterior horn cells because they didn't know what to do with the spasticity at that time when we didn't have toxin, you know, all those stuff. But once the Botox came into the market, somehow over the period of time, it lost, the uses has gone down and for the many reasons. I can't imagine before ultrasound, when ultrasound was not available, it must have been challenging because it can take a lot of time, especially if people have severe spasticity where joints are not in the normal position, where they're pronated excessively or adducted, it would be really challenging to find the location of the nerve. And of course, there are a lot of concerns for side effects too. So phenol is a great tool if you know how to use it, but if you don't know how to use it, you can cause a lot of problems. So that's the main thing you have to know. So for somehow it lost art, but in TR Memorial Hermann, where I work in Houston, Texas, we continue to use this and we kept it alive. And I think because of that, we are able to help many patients in many ways. So now chemoneurolysis and nerve blocks. So one is the permanent neurolysis or more something long-term, right? For which you can use phenol or ethyl alcohol. But you can also use lidocaine 1 to 2% for diagnostic block as well. And we'll talk about when the lidocaine is, you know, maybe it might be a better option to try a lidocaine, a trial to see how it's going to look like when you do the phenol, if you're really concerned about making somebody too weak. In general, it's indicated for focal spasticity management. You can either use 6% phenol or 50% ethyl alcohol. In many places, actually, they use ethyl alcohol. But ethyl alcohol, what I heard is it's a little bit more painful than phenol, actually. Now, both phenol and alcohol can cause demyelination of the nerve or Wallerian degeneration of the axon. And it depends on the strength of your phenol you use. Let's say if I use 3% phenol instead of 6%, it will only cause demyelination. And you need 5 to 6% for axonal degeneration to happen. So if let's say if you use 3% phenol, you cause demyelination, you will still see the immediate improvement in spasticity, but the nerve can remyelinate very quickly. So the effects will not last very long. Your patient will come back and tell you, oh, I had a great results for 2 weeks, but spasticity came back in 2 weeks. Then you know that somehow your phenol was not 6%. And also phenol actually evaporates. So if you load it in a syringe and you leave it outside without keeping it covering or properly, it will evaporate and 6% might become 3%. So I have my nurses draw the phenol in front of me just before I inject. And then beauty of the phenol is that when you are injecting, it has immediate transient anesthetic effect. So when you're injecting it, you see immediate response. So you can tailor your dose based on the immediate response. And I love that. And to be honest, I have, last 6 years I have injected, I don't know how many people. I might have 1 or 2 cases where people felt weaker with Botox, but I never had not even one patient where people felt weaker with phenol, because as I said, I can tailor it while I'm injecting. I can do a little bit of injection, check the tone and see how is the strength and the tone balance, and decide whether I can do more or not. But one thing is, if we inject, it's very important that we inject smaller amounts, because if we inject high amount, it can actually cause muscle fibrosis. So you're making the problem worse and you're not helping with that. So now there are no research studies or trials which tells you what's the best dose, recommended dose. But in general, consensus from the literature recommends no more than 1.2 milligram in total, which means 20 mLs of 6% concentration of phenol, you can use it up to 20 ml. But if you really develop that skill, you barely need that much either. Nowadays, I don't even recall if I used more than 10 ml in last 2-3 years, unless I'm doing bilateral upper and bilateral lower and multiple nerves. So phenol can be performed. So I'll show you a picture. So the main nerve trunk, you can do anywhere along all the way top from the main nerve trunk to the motor end plates along the course. Let's say if I do the main nerve trunk and completely separate the fibers, basically he's going to lose all the strength. For example, if I do the femoral nerve all the way up around, inguinal canal or somewhere in that area, he's going to completely become flaccid in his quads because I've completely killed the nerve, right? So you lose the quads 100%. But if you come down, and but you only inject motor points. Motor point means where the nerve branches enter the muscle. That's the junction is called motor points. So if you just target 1 or 2 motor points, then, you're not killing the whole quad, right? Only you are doing partially denervating that nerve, which is right now suffering from excessive spasticity. So it depends where you inject. Sometimes I even inject around the motor end plates, just the way you do it for the Botox sometimes, and it works for the smaller muscles. Usually I use both ultrasound and e-stim. The ultrasound makes it so much easier to identify it, and also it helps you to use very small dose, because with the ultrasound you can see that you're right on the top of that nerve branch or wherever. Because let's say if you don't use ultrasound, you can still do it, and a lot of people do it with the e-stim. So you really have to make sure if you're using the electrical stimulator, you are getting the maximum stimulation at the lowest intensity of the current. In general, actually, people use 0.5 to 1 milliamp, but I know the Clavis doesn't even have 0.5, so we usually we use 1 milliamp. So if you're really right on the top of the motor point or somewhere, the lowest current, like 1 milliamp, you should be able to see the muscle spasms. Otherwise, you're away. If you are requiring like a 5 or 6 milliamp current when you use the electrical stimulation, it means that you are away from the nerve. So even though you will do tons of, you put the phenol, if it's not right on the top of the nerve, you will not have the effect. And not only that, you will end up causing a lot of muscle fibrosis if you use a lot of volumes. Now, what are the, where can you use the phenol? I mean, to be honest, you can use it for any muscle, but in general, in my practice, I try to keep it the phenol for the bigger muscle groups, like pec major, your latissimus dorsi in the back. So both pectoral nerves and thoracodorsal nerve for latissimus dorsi are the motor nerves. So you don't have to worry about losing sensation. You can also do musculocutaneous nerve, but remember it's the mixed nerve, right? So if somebody has elbow flexion contracture, which you often see in stroke, and brain injury. So, you know, a lot of times my therapists come and ask me when patients are like this, that am I going to lose, or you're going to make them weak? Okay, if I don't inject, if they're stuck like this, do you think they can do anything therapy wise? No, they can't. So it's very important you treat spasticity, whatever you need. But now coming to musculocutaneous, it's a mixed nerve. If you do phenol to a mixed nerve, then people will lose sensation in the whatever nerve, whatever area is supplied by that nerve. So it's very important you know those, like which one is motor, where is sensory fibers come off. So you just do the motor points. So musculocutaneous, if you do in the axilla, then you will lose the sensation, right, on the lateral aspect of the forearm. So you can just do the motor points. So where do you find motor points? You find the motor points in the muscle, you know. We'll share some videos so that you will have an idea what I'm talking about. You can even use it for wrist flexors too, but you have to be very careful though, especially in the forearm, all the muscles are together. If you accidentally put too much volume and because medial and ulnar nerve, they're all mixed nerves, right? So they can lose the sensation in once you develop the skill enough, you can do even any muscles in the body. So I was just talking motor unit, you know. So let's I know this is right now here is axon, but let's imagine it's a nerve trunk. So you can do anywhere from here, and then small peripheral branches also you can do where they enter. And then let's imagine this is a muscle. So if this is where the nerve is entering, you call that as a motor point. And then eventually it goes and, you know, motor end plates where the neuromuscular junction. You can even inject here and it still works. It doesn't last very long. And also you have to do multiple injections, but you even use it as a Botox, but you have to do very small volume. Now, what are the indications for chemoneurolysis? So I'll tell you how I use in general in my practice. So sometimes, you know, I have patients with spinal cord injury, let's say quadriplegic patients. So you have both upper extremity and lower extremities are involved. I know that in that case, you should think about intrathecal backflip and pump, but somehow I find it my patients with spinal cord injury are often very resistant to backflip and pump because they already had a spine surgery, and you talk about another surgery, many people are really apprehensive. So, you know, I explain it to them and educate them, but at the end, I do what patients want. I don't want to force it, but I definitely try my best to educate them. So in that scenario, do you think if you have to take care of spasticity, which is not, you know, your oral baclofen or tizanidine is not even touching with just Botox, and actually in United States, it's most of the insurance limits 600 units of Botox, which I can't do it. Bilateral upper and lower extremity, even sometimes bilateral upper, if multiple muscle groups are involved, I can't do it. So that's a good time that you can keep the Botox for small muscle groups and use the phenol for bigger ones, especially pecs, lats, hip adductors. So I think I totally stopped doing actually Botox for pecs, pectoralis major, latissimus dorsi, and hip adductors because phenol works beautifully actually for those muscle groups. And the other reason I use phenol for bigger muscle groups, and you know when your shoulder adductors and internal rotators, especially pecs, can be so problematic, right? I remember when I joined the tier, whenever I would see a patient like this, I made a promise to myself that I don't want anybody to be like this, you know, not even be able to open up their shoulder. You know, it's a hygiene issue. Sometimes when the people come, I do them phenol and I clean up tons of stuff underneath the axilla. So when bigger muscle groups are spastic, you need much more, you know, how much Botox can you put in the big pecs and lats and hip adductors, tell me, and get the adequate relief. So phenol works, as I said, beautifully in those cases. And nowadays we don't see any sensitivity to Botox injections, but Dr. Francisco tells that maybe 10 years ago, you know, some people had allergic reactions, but I know nowadays botulinum toxins are much more purified versions. And some people, as I said, you know, I tried Botox for them, but when you have these big muscle groups involved, and often, even if you use the higher dose, it's not enough. And some of you might know, especially these pecs, you know, hip adductors, sometimes people comes with the legs crossed, you know. It's really challenging. Even though you do Botox, it doesn't even help touch them. Cost reduction. So Botox is super expensive, right? Phenol costs nowadays, because alcohol is very expensive since the COVID-19, so it became a little bit expensive, but otherwise a small 10 ml bottle, still it's you know, it was like maybe $10. Now it costs $40 with the alcohol, all the issues with alcohol nowadays. And now, not a candidate for intrathecal baclofen pump, even though sometimes you have spasticity everywhere. There could be many reasons that he's not a candidate for intrathecal baclofen pump. Maybe they don't have insurance to be able to cover that, or their back is fused that you can't even do a trial. I have few of those cases. Or if they have an ongoing infection, or you know, they had a PE and they're on Coumadin or something and they can't come off that. So there are many issues that, you know, when people are not a candidate for baclofen pump. Since I do mostly spinal cord injury, but I do take care of CP, cerebral palsy, and multiple sclerosis as well, but mainly application in SCI. So severe spasticity, as I talked about, involving bilateral upper and lower extremity, whereas especially in incomplete spinal cord injury people who are, you know, where I find more challenging to treat spasticity, people with a complete spinal cord injury, it's easier. I don't have to worry about functional loss that much. I only have to worry about at that time just to how can I help patient be at ease, ease of caregiving and hygiene. But incomplete spinal cord injury people who have more function and who can even walk, you know, it's very challenging to manage the spasticity because you have to have a fine balance where you do not cause any problem with the function, loss of function, at the same time you treat spasticity. So I often find actually intrathecal baclofen pump more challenging in them. So that's the case, you can do it. And also, you know, inpatient setting, when patient is in inpatient rehab, you don't have that much time, right? Where you can do the Botox and wait for 2 weeks. Sometimes we need quicker results so that, you know, therapists can work with the patients. So that's the other scenario. For many of my inpatients, I do phenol all the time, actually, and it works great. Just wanted to show you some of the scenarios where I had to use everything from my toolbox, like a baclofen pump, phenol, and Botox. I mean, if you see person in the right side in the picture, he has elbow flexions, pronator is type elbow flexion contracture, wrist flexion contracture, plus spasticity, pronators are involved. Actually, this was actually after the phenol. His legs were all crossed and twisted that I didn't even know which one was right leg and which one was left leg. And then knee flexors are involved. So tons of muscle groups, you know. While we were waiting for ITB pump, we did the phenol for his hip adductors. We did Botox, phenol, combination of everything to help him to get somewhere where he was able to sit up in the chair. Similarly, this patient too, if you delay spasticity management, see, often we are so worried about losing function or maybe that people are not going to recover if we treat spasticity sooner. This is what's going to happen to them. And many of you might have seen. So do you think if somebody becomes like this, they're functional? No. If anything, treating spasticity sooner, I have seen they do much more better functionally, actually. Now we're going to talk about the technique a little bit. As I said, it depends where you inject. You will not make people weak if you do just some of the peripheral branches and just few motor point blocks. And as I again said, that phenol is an anesthetic, so you can see immediate response. So based on that, you can titrate it. So now your E-stim will help you to identify the motor point, right? So when you use the electrical stimulator, so this is Clavis. There are many other brands too. This is what I use at TIER. I'm not promoting Clavis or anything, but when I went to Peru, we used some other and it worked great too. So you can use whatever brand you have, but this one has both EMG guidance and E-stim guidance. So when you use the E-stim and under the ultrasound, when I'm looking at the motor points, so when your needle touches that motor point, your muscle should spasm, right? When you're touching that nerve, you think that that's a nerve and you're touching it with the tip of the needle, but if it's not spasming, most likely it's a sensory nerve. And if patient has sensation, he will tell you that, oh, I'm having pain or something. So you don't inject if you don't get any muscle stimulation. So that's the purpose of using the electrical stimulation, to make sure that it's a motor branch. Because as I said, again, if you inject a sensory branch or if you inject a mixed nerve, people will lose sensation over that area if it's a complete block. But if it's an incomplete block, then they will have a severe pain, because basically it's a complex regional pain syndrome, right? Because of the nerve injury. So it's very important that you identify the motor points. Now, while I say that you shouldn't inject if you don't feel the muscle spasms, I'll tell you there are some scenarios in which patients come to me very late and the muscle has been so tight and tonic, in a tonic state for so long, that even when you put it on it's just so tight that even when I'm stimulating the nerve, it doesn't spasm. So once, of course, now I've been doing it for long enough. So now I know that for sure. For example, PEGs, I know they're only motor nerves. They're not, it's not mixed nerve. And I've been doing it long enough that I know where the motor branches lie. So there are some scenarios where I don't get spasm because the muscle is just so tight like rock. I go ahead and inject. And after you inject a few motor points, then your muscle loosens up, then you start having spasms. So there are some scenarios that you may not get spasms if the muscle is too tight. But unless you're confident, I wouldn't recommend, unless you know that this is just motor nerve, like for example, for latissimus dorsi and PEG, then you can inject. As I said, maximal response for minimum current is shout. So basically 0.5 to 1 milliamp or maybe max 2 milliamp. But if you're going more than that. Now remember, response is going to be different. If you're doing the main nerve trunk, like obturator nerve, if you're doing it the obturator foramen, you will have a strong spasms. But as you come down and do just the motor point, you will still have the spasms, but they won't be same as you find it when you do the main nerve trunk. Okay, and when we are doing a little bit of motor end plates, you will just see a tiny spasms on your ultrasound screen, but you wouldn't see like a strong visible spasm. So also spasm intensity is going to be different depending on which part of the nerve or where in the course of the nerve you are stimulating. Okay, and we do still use the Teflon coated EMG needles because it's so much easy. And remember, phenol in general is more painful than the Botox, especially when you're doing the PECs and all that. And sometimes if people have sensation where you are injecting phenol, they can even have some pain, but it doesn't last very long. And each site, and this is the key, each site, you do not need more than 0.2 to 0.5 cc. So sometimes what I have seen, even my residents and fellows, because when you have the needle and you're using the electrical stimulation, even though you are injecting, you are still getting, muscle, you're still getting, because of the electrical stimulation, muscle spasms. You don't have to inject until you totally stop the muscle spasm, because phenol takes a little bit of time to start working. So you have to control yourself and just inject 0.2, 0.5 cc. It works beautifully. You have to trust, but only if you are right putting it on the top of the nerve. All right. I don't have very nice fancy videos, but let me see if I can play this here actually. Oh, because I'm using it in Office 365, I'm not finding, just give me a second. Maybe I can play here. Okay, I'm not very good at video, but just focus on, so you see how you see the stimulation when I'm injecting in, it's on the ultrasound screen. Okay. Just a second, it's loading.
You can take the spasm spinach here too in the hands too.
And you can see I'm doing elbow extensors, and see I found the motor branch, and you saw the stimulation. Yeah. Okay. Go back now. Okay. Now here I'm putting right on the pecs. Okay. So here it's on the top, it's skin, it's pec major, pec minor, and this is actually rib, and usually here your pleura. So I can't imagine how people would do it blindly when you didn't have ultrasound, because it's very high risk of having pneumothorax, right? So your medial and lateral pectoral nerves, usually they both nerves, they go between the pec major and minor. So you see this white bright light when you are under ultrasound, they're, the nerves accompany vessels, right? So you will find some small blood vessels, and the nerve branches will be right next to that blood vessel in this white line. And once you start doing it, use ultrasound, then you will know. So that's where you inject for the pecs when you do the phenol. Just the ultrasound images. So let's say if you want to do FCR or pronated teres, just like the way you do the Botox, make sure you use the E-stem. So usually the motor end plates and some of peripheral branches, for example, how they appear. So this is ultrasound image, right? Do you see all these white hyperechoic spots? Usually those are your motor end plates. Wherever you see this white hyperechoic spots, this is fascia, and the nerve is lying around the fascia. But in the pec minor, if you see these small white stuff under ultrasound, if you put your electrical stimulation needle out right there, it's going to start giving you the stim. So you can target those places as well. And just to show you, here, so for latissimus dorsi, which also causes the internal rotation and shoulder adduction, right? So in your posterior axilla, if you put your ultrasound in your posterior axilla, it's right at the bottom of your latissimus dorsi. You will see this thoracodorsal nerve. That is your target. If you're worried about puncturing the lung, then you can always find a spot where it is right above the rib, So I know phenol, I can tell you so much, but really I think to be able to learn this skill, I think you really have to have some kind of workshop or 101. Happy to have you, any of you, to TIER if you want to come and observe me. Now for, let's say if you do want to do obturator nerve, and trust me, obturator nerve, once you do the phenol, you will never use the Botox for it because it works beautifully. So the target is usually, let's say if somebody is a complete injury or so severely adducted, you can do it right here, in this area. So now how do you reach here? So if you want to do obturator nerve, it's always better that you flex your hip and externally rotate the way you see in the middle of this picture, okay? And then once you are in that position, you open up your obturator foramen. So there are two ways you can identify the obturator nerve. One, you find femoral vessels, right, in the inguinal canal. Once you open up in this area, if you put your ultrasound probe here, you will first find the femoral vessels. And as soon as you find the femoral vessels, you just go little medial, and then you will see both anterior and the posterior branch. And you can just inject one anterior branch. You don't have to inject both. Just if you inject the anterior branch, you will have enough spasticity relief actually. And remember, obturator, though it's a mixed nerve, but it has only small area where it supplies the sensory on the medial side of the knee, just the coin size. So usually if I have to inject in somebody who is severe hip adductor spasticity, I go ahead and inject the main anterior branch because it's just the small area of, sensation. People never complain about that. Now you can also do plantar flexors. You might have also find challenging to treat plantar flexor spasticity, right? They're notorious muscles. So if you want to do the tibial nerve, remember tibial nerve is a mixed nerve, okay? So if you inject it above popliteal fossa, then you are basically killing the sural nerve and also all plantar nerves of your feet too. So person will lose sensation, the calf and in the bottom of the feet. So you don't want to do it above popliteal fossa, okay? Let's say if you do at the popliteal fossa, then by then, you know, the sural nerve branches are already comes out. So then you will not have, the person won't lose sensation over the calf, but you still have sensory fibers that supplies to the sole. So if you inject in the popliteal fossa, sometimes, you know, we can get tempted because the response is so good, you know, when you inject in the popliteal fossa because you're killing main nerve. So immediately somebody who's stuck in the plantar flexion, you can have, if they're not contracted, you know, you can have immediately gain range, but then they will lose if they have sensation. If they don't have sensation, don't worry about it. But if they have sensation in the bottom of the feet, they might lose sensation even if you do in the popliteal fossa. So if in a person who is in complete injury or have sensation, you do motor point block. No, so you draw a line, so you see A and B between the two condyles, and right 1.5 centimeter below it, you come down and 2 finger breadths on either side. Basically main bulk of your gastrocnemius, that's where you find the motor points, the nerve branches, and that's where you inject if you don't want any sensory loss. Now, one thing I'll tell you, I had 3 cases, even though their patients were complete spinal cord injury. So I injected them here at popliteal fossa. They had great results. Their ankles were stuck like this for a long time. But since you injected the main trunk, they had, while the Wallerian degeneration is happening, Wallerian degeneration means when the axonal is dying backwards. While that's happening, people had temporarily had severe swelling of the limb and also discoloration and the pain, but not pain because they were complete injury. And I wouldn't have believed them because they took the picture. There were 2 patients and brought it to me actually. By the time they came, because it takes 9 days for you to 9 to 10 days to Wallerian degeneration to happen, right? And once that completed, then swelling resolves. So I think it's more like a temporary CR sympathetic response. So I had 2 cases like that when I did the main nerve trunk that happened, but I never had that problem with obturator. It was only the plantar flexors that I had with the tibial nerve. Just an example, for example, see how patient had. So I have noticed that almost always the elbow flexion, you know, when you see somebody like this, there is always a component of contracture too, okay? So he came to us like this, okay? We did the fenol and see immediately after fenol how much we were able to open up, right? That's cool. Somebody who was like this, and we were able to make him. Then we did some serial casting. See, if you do phenol or Botox or ITB pump, that's only the one part of your treatment, right? You still need to do stretching because whatever I do, it only relaxes the muscle. But what about the other, like a tendon, or sometimes, you know, you have some other fibrous tissue, or there are other things too, right? Besides the muscle, if the tendon or joint contracture, you cannot fix that with the phenol or Botox. So you need stretching, serial casting to see. And after serial casting, he achieved a lot more range here, which I think, and all these things happened within a very short span, like within 10 days, we were able to get there. Do you think with the Botox, I can get these results within 10 days? No, probably. Because, and also the problem with the Botox, you make your best guess and you do a certain dose. But if it didn't work, that dose didn't work, then you have to wait for 3 months. So basically that you're delaying the care of that patient. All right, so look at here. I mean, see, if you see somebody like this, I wish he could get the intrathecal baclofen pump, but as I said, families refuse, or sometimes a medical condition doesn't allow them to have the pump at that time. I mean, somebody's like this, I can't imagine keeping him there to wait for him to get better and get the pump. So then we did his hip adductors, and we were able to keep it without getting tangled and position him properly. Same thing here also. Oh my God, this patient was such a, I would say, we literally had to do artwork for him, the way he came to us. And you see with the phenol and the braces and everything, how positioning is so much better compared to here and here. And actually when this patient came, he was bed bound for, you know, I don't know, he did not even got out of the chair since his injury, and he was on bed. But I know Dr. Hernandez and I were his attendings, and we literally did a lot of work along with our awesome therapist team, where he was somebody who never got out of the bed to the chair for many months since his injury. I think at least it was 6 or 7 months. But after, you know, we even had, and his, both the arms were all the way up to the chest. So how would he even operate the chair? So we were able to give him enough range and enough, you know, able to control his spasticity enough where he could sit up in the chair. And actually he was able to operate the chair by himself. And even he stood in the standing frame. Now, whereas as I was talking about all the good things about phenol, as I said, if you don't know how to do it properly, you can cause pain, bruising, especially dysesthesias. If you inject the mixed nerve, like for example, the tibial nerve, but if you do an incomplete block, people can develop CRPS, right? It can cause a CRPS type 2 pain. So what do you do if somebody develops their dysesthesias, very painful sensation? You just go back and complete the block. So you go back to make sure you completely block the nerve. So they will lose sensation in that area, but then they won't have the pain though, you know. So that's the solution for that one. As I said, swelling of the limb I have seen, but the risk of these reactions is less than 2%. And just it was actually just 1 year data. You know, we are 3, 4, 5, 6. At here, we were 6 of us, but mostly 3 attendings. Actually, Dr. Gutierrez left to a different institution, so now with 2 of us, we do pretty heavily phenol. And this is just the 1 year data. And you can see in our institution, probably we did 877 nerve branches. And I don't recall having any severe adverse reactions or anything in our institution. And I think we were able to help. So there are not much in the literature about the phenol. Actually, from our institution, Dr. Francisco and Dr. Lee published this paper. And actually right now we are writing in people with SCI, both a book chapter and publishing a similar paper. And in this paper, actually, it was a retrospective cohort study. We looked back and see how many injections we did for how many people. So it was mostly stroke, traumatic brain injury, and spinal cord injury people. And most common nerves injected in upper extremity were the pectoral nerves and musculocutaneous, and lower extremity, sciatic, tibial, obturator, and femoral. If you will ask me, in my spinal cord population, probably in lower extremity, most commonly injected is obturator, and in upper extremity, pectoral and thoracodorsal. So, you know, post-injection improvement was reported in actually 60% subjective, whether patient felt or not, whether, you know, so subjective improvement we saw in pretty much 84% of the patients, which means 84% of the, you know, in the nerves injected, but total overall 55% of the patients reported improvement. But, you know, always the subjective, what patients' goals are often different than what our goals are. So if they don't see an improvement in the function, they think that it didn't help. It happens so many times, then I have to redirect them that what I was doing is to help with your spasticity. But if you don't have strength in your antagonistic muscles, like say somebody wanted to extend their elbow, my goal was to give him the range. But if you don't have elbow extension strength, he's not going to be able to extend it, right, actively. So you have to really talk to them about the goals very clearly. Now, among the 279 procedures, you know, there were no adverse effects. So some kind of adverse effects were reported only in 14 procedures, you know. What were the common adverse events? The pain, which was temporary, inflammation, which was also temporary, and dysesthesias, it was 0.68% actually. And dysesthesia is because of the incomplete block. Most of the procedures with adverse effect involved peripheral nerve, tibial and the femoral nerves. So these are mixed nerves, right? So that's when you will have problems. And then there was another paper published from, this was also from the Tier Memorial Hermann, in which they talk about doing injections to 57 patients, and they did 139 nerves, neurolysis. And again, people were TBI, stroke, and SCI. So this is important. See, the average dose per nerve was 1.3 ml. So it's not a lot. I have seen many people actually keep injecting huge volumes, which is not recommended. So in this case, actually, they tested it in the muscles innervated by radial, ulnar, and medial nerve, which is not commonly done. But even here, when you do it up with appropriate skills, you can see that people, only there were 3 cases where people had a little bit of prolonged pain, but no dysesthesias, and this was temporary. And during the follow-up period, the pain was gone in all these patients. So this is just a quick picture. If you use the ultrasound machine, so the bottom line is the volumes used, phenol volume used with the ultrasound. And the top one is with the e-stim guidance. So you can see when the people use with ultrasound, the volumes are much lower compared to e-stim alone on the top. So ultrasound volume can increase the precision and also the volume required for injection significantly. So that's what it's a really important tool for you. All right. That's all. I know this is more like information about the phenol, but to learn injection, I think really we need some workshops. Maybe in future we can do some, I don't know, online live workshops. I don't know how it would work with the HIPAA perspective, but that's something to think about in future. All right, questions or anything?
So Radha, I think we're going to